Today, I would like to continue our conversation regarding tobacco and smoking cessation. As we draw closer to the Great American Smokeout on November 16th, I will continue to share more information from the American Lung Association and other sources. American author and activist James Baldwin noted, "Nothing can be changed until it is faced." In a time when structural and social inequities facing Black Americans are being brought to the forefront of social conscience, it can no longer be ignored that tobacco is a racial justice issue. To make health equity and tobacco control a priority, it takes firm commitments to policy interventions to increase tobacco success for all people of the Black community and to create parity of health benefits. The U.S. has expanded laws and policies protecting people from tobacco since the first U.S. Surgeon General's report in 1964. There's less smoke in the air, and there are fewer advertisements for harmful products as a result. But these protections, which most Americans now take for granted, are less likely to cover the places where people of color live, learn, work, and play. They are also less likely to cover rural areas. The Frameworks Institute, in partnership with a working group composed of diverse community-based partners, identified the following drivers of tobacco product disparities. The tobacco industry pressures some groups with tailored marketing tactics. Some Americans are protected from secondhand smoke while others are not. Corporate marketers use flavors to entice specific groups to try tobacco products. Access to treatment for tobacco-related health issues varies widely by population, geography, and other variables, and discrimination increases stress, driving higher rates of tobacco use for some groups. There are many commonalities to the drivers of health disparities and tobacco disparities. This reinforces the importance of considering the greater social forces that may be driving tobacco product disparities. Leading voices in tobacco control recognize that equity issues must be elevated, but with sensitivity. If not carefully worded, communications could inadvertently reinforce unproductive misconceptions and biases about the communities who are most affected by tobacco-related diseases. Each play a role in addressing tobacco disparities. Black people suffer disproportionately from tobacco-related illnesses and have more difficulty quitting tobacco products than white individuals who smoke. Notable barriers to eliminating tobacco use among Black Americans are low socioeconomic status, mistrust of government and organizational institutions, lack of cultural competence in healthcare settings, and the ongoing presence of aggressive big tobacco marketing campaigns in Black communities. Low socioeconomic status. Despite significant economic progress over the past decades in the U.S., Black Americans experience far worse economic conditions than white Americans, or the population as a whole. Individuals of lower socioeconomic status, i.e., those who have lower levels of education, are unemployed or live at or near or below the U.S. federal poverty level, have higher rates of smoking than the general population. According to the CDC, for example, 20.4% of people making less than $35,000 a year smoke, compared to 6.2% of individuals making $100,000 per year. Research shows that from 1967 to 2017, Black Americans had the lowest median household of any other racial group. Furthermore, nearly 19% of Black Americans live in poverty, the highest rate of any race. Low socioeconomic status is a key social determinant of health that poses a significant challenge to tackling the tobacco use rate in the Black community. Mistrust. Studies have shown that Black people report lower levels of trust in hospitals and healthcare providers than white people. Mistrust can also reduce the likelihood that a patient will seek medical screenings or follow up with recommended treatments. The Tuskegee syphilis study has been cited as a major cause of mistrust in the healthcare system. However, today Black Americans still experience differential treatment. One study found that half of medical students and residents held one or more false beliefs about supposed biological differences between Black and white patients, like the false belief that Black patients have a higher tolerance for pain because they have thicker skin, Other factors that reduce trust include the healthcare system often minimalizes the physical and emotional tolls of exposure to police brutality, substandard housing in schools, polluted neighborhoods, or other parts of the daily experiences of some Black Americans. Lack of cultural competence in healthcare settings. Cultural competence, which we have discussed before, is defined as the ability of providers and organizations to effectively deliver healthcare services that meet the social, cultural, and linguistic needs of patients. Oftentimes, Black patients and other minorities are spoken to rather than talked with. The lack of cultural competency and good communication can be directly linked to misdiagnoses, less empathy and acknowledgement of concerns, and overall poor health outcomes. One study shows that there is a considerable evidence that even well intentioned whites who are not overtly biased and who do not believe that they are prejudiced typically demonstrate unconscious, implicit negative attitudes and stereotypes. Poor cultural competency is failing of the healthcare system and not of patients. When providers recognize that each patient comes with a range of previous experiences with healthcare, some of them based in trauma, various literacy levels, language fluency, and cultural norms, they can begin to engage equitably and respectfully with everyone who seeks care. Health systems and practitioners must recognize and respect the needs of a diverse population, promoting equity of access and patient safety. However, many other strategies must be undertaken in addition with training and education to improve cultural competency, to eliminate racial and ethnic disparities in healthcare. Now, I've heard it said that we should change cultural competency to cultural humility. Can you ever really be competent in someone else's culture? I think not. And we're going to stop right here. This is a lot to digest. Please join me next time when we'll discuss understanding Black smoking behaviors and physiological differences in our continuing discussion of tobacco and smoking cessation. If you have any questions regarding the information I have shared, please reach out to me, Dawn Daly-Mack, RN, at 252-410-1717. The Great American Smokeout is November 16th. It's a good time to quit and improve your quality of life. And always remember, Black health matters.